دكتور.
ماشي. بسم الله الرحمن الرحيم. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. I am really pleasure today to have one of great professors from Alexandria University as speaker and another great professor as the moderator. So for this session. So this session is for Alexandria University. Our moderator is Professor Iman Gohari, Professor of Nephrology and Medicine in Alexandria University, and one of the very professional team that organizes both scientific and official organization for NephroAlex each year, which is one of the great nephrology congress in Egypt. I think it is the second one after ESNT Congress. Our speaker today is Professor Tamer Elsherbiny, Professor of Endocrinology in Alexandria University. And I will leave the floor to Professor Iman to further introduce Professor Tamer regarding his professional work. And today we will discuss the topic of high electrolyte disorders related to endocrinal disorders, both from the nephrology aspects and endocrinology aspects. We are, as nephrologists, are concerned mainly with electrolyte disorders, and many of these disorders are related to endocrinal problems. So we expect Professor Tamer to illustrate how to diagnose and how to manage these from endocrinal point of view, and to add the nephrological aspect of view from Professor Iman. So please, Professor Iman, take the floor to further introduce Professor Tamer, and we'll come to you after the discussion, after the lecture for the discussion. Before we start, I would like to thank all our attending professors or our attendees and our coordinator, Dr. Hazm Abu Shusha, who is the Fellow of Egyptian Fellowship of Consultant of Nephrology and the Fellow of Egyptian Fellowship of Nephrology in Egypt, for all of his work regarding CME chapter and the specialty session. Please, Professor Iman.
Okay, thank you, Dr. Yasser, for this kind introduction. It is my great pleasure to introduce my colleague, friend, and even student, Dr. Tamer Elsherbiny. He's a great and eminent professor in endocrinology in Alexandria University, and he's the head of endocrinology unit in internal medicine department of Alexandria, and he is also the vice dean of Alexandria Thyroid Association. He will give us today a hint about endocrine perspective and of electrolyte disturbance, and I think he will concentrate on hyponatremia in endocrine diseases. Dr. Tamer, the mic is for you.
Thank you, Dr. Iman, for the nice introduction. Thank you, Dr. Yasser, for the invitation. So covering the topic of electrolyte disturbances in one session would be a difficult task to do. That's why I have concentrated in this presentation on discussing hyponatremia. I'm going to discuss hyponatremia from the endocrine perspective. So the agenda that we are going to cover today is what are the endocrine causes of hyponatremia, the diagnostic challenges that we face while diagnosing endocrine causes, what is a diagnostic workup, and at the end, I'm going to show you 3 real cases that I have already encountered in my practice that presented with hyponatremia, and they were revealed to have both adrenal insufficiency and hypothyroidism as a final diagnosis. Starting from the endocrine causes of hyponatremia. So we don't have an extensive list. We actually have a short list: the primary adrenal insufficiency or Addison disease, secondary adrenal insufficiency, and hypothyroidism. We are going to cover each one in detail. Okay, so starting with primary adrenal insufficiency. So primary adrenal insufficiency is also called Addison disease. I'm just going to talk more about this topic. It is very common practice that when a patient presents with hypotension in an emergency department, that he would be diagnosed with Addison disease. So actually, in our practice in Egypt, we are having an overdiagnosis of Addison disease. That's why I'm going to illustrate what is Addison disease, what is the difference between primary and secondary adrenal insufficiency, and how this condition, because as I told you, it is being overdiagnosed in emergency departments and it is being overtreated. So Addison disease does not refer to adrenal insufficiency in general. It refers to specifically primary adrenal insufficiency. Primary adrenal insufficiency or Addison disease is actually a rare disorder. So the annual incidence of adrenal insufficiency or primary adrenal insufficiency is estimated to be 2 to 5 per million population per year. So this is a rare diagnosis. Almost 99% of patients admitted to the emergency department with only hypotension without any other cardinal signs of primary adrenal insufficiency receive the diagnosis of Addison disease. So that's why we have to be careful before considering the diagnosis of Addison disease. So what happens in Addison's disease is that the adrenal cortex as a whole is affected. And that's why these patients will have cortisol deficiency, aldosterone deficiency, and adrenal androgen deficiency. And that's why you can expect the presence of hyponatremia easily in a patient who has primary adrenal insufficiency. So the mechanism for hyponatremia in a patient with primary adrenal insufficiency is aldosterone deficiency. So we know that aldosterone is responsible for the reabsorption of 5 to 10% of the filtered sodium, and this occurs in the distal convoluted tubule. So in absence of aldosterone deficiency, we should expect that this 10% of filtered sodium are not going to be reabsorbed. Normally, the reabsorption of sodium occurs in exchange for potassium and hydrogen. So what happens here is that we lose 10% of the filtered sodium. When the filtered sodium is lost, fluid is lost along with the sodium. And so these patients would have hyponatremia and hypovolemia. And because potassium and hydrogen are retained, so these patients are also expected to have hyperkalemia and metabolic acidosis. So the whole metabolic constellation expected to occur in a patient with primary adrenal insufficiency, that the patient would have hyponatremia, hypovolemia, hyperkalemic metabolic acidosis. At the time of the original description of primary adrenal insufficiency or Addison disease by Thomas Addison, and this was back in the 19th century, the most common cause of primary adrenal insufficiency was TB adrenalitis. However, nowadays, the most common cause of primary adrenal insufficiency or Addison is autoimmune adrenalitis, and this constitutes up to 80% of the cases. Less frequent causes include infections, so tuberculous adrenalitis, which was the most common cause in the 19th century, now comes second after the autoimmune adrenalitis. Metastatic carcinoma to the adrenal glands can cause primary adrenal insufficiency, and that's why when we are dealing with patients who present with adrenal masses, only when the adrenal masses are bilateral that we consider the possibility of having adrenal insufficiency, and so we do not seek to exclude the primary adrenal insufficiency except that if we have bilateral adrenal masses. Several medications can cause primary adrenal insufficiency, the most famous of which is the famous antifungal ketoconazole, the famous anti-cancerous metirabone. And actually, these drugs that can cause primary adrenal insufficiency, we actually utilize in the management of some patients with Cushing disease or Cushing syndrome, because such patients who may be unfit for surgery, we use such medications to achieve what we call medical adrenalectomy. So what can be considered as a side effect and can cause primary adrenal insufficiency or Addison crisis or hyponatremia, as we discussed today, we actually employ or we actually utilize as a useful tool to manage patients who have cortisol excess. The other type of adrenal insufficiency is the secondary adrenal insufficiency. actually secondary adrenal insufficiency is far more common compared to primary adrenal insufficiency. And the major difference is that in such cases, only ACTH is low or absent. And that's why this is going to decrease cortisol secretion. However, aldosterone levels are not affected because we know that more than 90% of the aldosterone secretion is actually controlled by the renin-angiotensin-aldosterone system. And that's why this is the major difference between primary and secondary adrenal insufficiency, is that aldosterone secretion is maintained. Of course, the second major difference between them is that secondary adrenal insufficiency occurs due to pituitary causes. The most common cause of secondary adrenal insufficiency is the sudden withdrawal of chronic steroid use. And because glucocorticoids are potent anti-inflammatory, potent immunosuppressive drugs, they are commonly used in the medical practice, and that's why if they are not properly used, if they are not properly tapered, such patients would have the risk of having secondary adrenal insufficiency. Other causes which may cause secondary adrenal insufficiency include space-occupying lesions in the pituitary or the hypothalamic area, like tumors, like craniopharyngiomas or Rask cysts. Infections like tuberculosis can cause this. Infiltration by histiocytes or infiltration by sarcoid tissues can also cause secondary adrenal insufficiency. It can be iatrogenic due to pituitary surgery, radiotherapy. It may be caused by empty cellular syndrome, or it may be caused by a rare disorder, which is called hypophysitis. Secondary adrenal insufficiency can present as part of ban-hypopit or multiple adrenal anterior pituitary deficiencies. And this is more common to be encountered in space-occupying lesions, and we have a specific sequence for the loss of the anterior pituitary functions. So space-occupying lesions or pituitary adenomas usually lead to the loss of the growth hormone and glucocorticoids at the beginning, and later they may lead to secondary hypothyroidism and secondary hypoadrenalism. This disorder is not maintained in other pathologies which may cause hypopituitarism. For example, in hypophysitis, it is most common that the adrenal insufficiency would be the first axis to be lost. Some causes of secondary adrenal insufficiency can lead to isolated loss of ACTH secretion, like traumatic brain injury and hypophysitis, especially those related to the side effects of the immune checkpoint inhibitors. So we have explained hyponatremia and primary adrenal insufficiency on the basis of aldosterone deficiency. And we have stated that the major difference between primary and secondary adrenal insufficiency is that aldosterone secretion is maintained in secondary adrenal insufficiency. And that's why the mechanism of hyponatremia and secondary adrenal insufficiency is totally different. So we have to remember that cortisol is considered to be a physiological tonic inhibitor of ADH. So the cortisol acts in relation to ADH or adrenaline vasopressin the same way as dopamine acts for prolactin. So cortisol does not exert negative feedback related to the ACTH and the CRF only. So cortisol also inhibits the secretion of adrenaline vasopressin or antidiuretic hormone. So that's why in such patients, when the cortisol is decreased or hypocortisolism, this is going to lead to inappropriate secretion of AVB or ADH. Also, it is suspected or postulated that hypocortisolism may lead to increased sensitivity of the kidney to the ADH. And lastly, because of the hypocortisolism, this may lead to decrease in systemic blood pressure and cardiac output, which is going to stimulate carotid baroreceptors, which is also going to stimulate the ADH or AVB secretion. There is another additional mechanism, which is actually ADH or AVB independent, because it is postulated in such patients that impaired renal hemodynamics may lead to decreased distal fluid delivery, which to the diluting segment, which is going to decrease the free water excretion. The third of the endocrine causes of hyponatremia is going to be hypothyroidism. So there has been a relation that has been cited once before that for each elevation of the TSH by 10 milli-international unit per liter, this is going to decrease sodium by 0.14 millimole per liter. The postulated mechanism that explains hyponatremia in a patient with hypothyroidism is a decrease in the cardiac output. So we know that thyroid hormones controls the expression of adrenergic receptors. So in patients with hypothyroidism, we expect a downregulation of adrenergic receptors expressed on the heart. And these adrenergic receptors control inotropic, chronotropic, and dromotropic properties of the heart. And so with a downregulation of the adrenergic receptors, this is going to produce negative inotropic, negative chronotropic, and negative dromotropic effects on the cardiac muscle, which is leading to decreased cardiac output. A decrease in the cardiac output is going to stimulate carotid sinus baroreceptors, which is going to stimulate ADH secretion. Also, because of the decrease in the cardiac output, this is going to lead to renal hypoperfusion. A renal hypoperfusion is going to decrease the glomerular filtration rate. With a decrease in the glomerular filtration rate, this is going to decrease water delivery to the diluting segment, which is also going to decrease free water excretion. So the most important two mechanisms to explain the presence of hyponatremia in a patient with hypothyroidism: first, the decrease in the cardiac output related to decreased expression of adrenergic receptors in the heart. And second, a decrease in the glomerular filtration rate, which is actually related to a decrease in the cardiac output, which is going to decrease the delivery of the water to the diluting segment of the kidney. Other less postulated mechanisms is related to some patients who were actually diagnosed with salt-losing nephropathy in association with hypothyroidism. It was found that patients with hypothyroidism may have inappropriate secretion of ADH, and this was explained that this was a resetting of the osmoreceptors, which is going to allow the secretion of ADH in spite of these patients being euvolemic. One of the most common causes of hypothyroidism is iodine deficiency. So in areas where they have iodine deficiency, they found that usually a low iodine intake is associated with a low solute intake, which is going to decrease the ability to excrete water. One last mechanism of probable explanation for hyponatremia in a patient with hypothyroidism is a coexistence with either primary or secondary adrenal insufficiency, which would actually contribute to hyponatremia. As I just mentioned, hypothyroidism and adrenal insufficiency may coexist, and they may coexist on different levels. So primary adrenal insufficiency due to Hashimoto thyroiditis may coexist with Addison disease due to autoimmune adrenalitis. And actually, this is known as the famous Schmidt syndrome. Schmidt syndrome is one part or one subclassification of autoimmune polyendocrine syndrome type 2. They may coexist also as part of hypopit. So we may have secondary hypothyroidism along with secondary adrenal insufficiency as part of hypopituitarism. Also, primary hypothyroidism may actually coexist with secondary adrenal insufficiency due to autoimmune hypophysitis. So both hypothyroidism and adrenal insufficiency, both primary and secondary adrenal insufficiency may coexist, and they cause hyponatremia incorporation. So we start with the diagnostic challenges. So a patient presenting with acute adrenal insufficiency, or that's to say adrenal crisis, is usually easy to diagnose. So the combination of having weakness, confusion, the GI manifestations of nausea, vomiting, diarrhea, and abdominal pain. In most of the cases, it is precipitated by infection. So the patient may have also fever, having hypotension, hyponatremia, along with hyperkalemia. In most of the cases, is enough to reach the diagnosis of adrenal crisis or acute adrenal insufficiency. Other supporting pieces of information may include hypercalcemia and eosinophilia. However, it is usually difficult to diagnose a case of chronic adrenal insufficiency. So cases of chronic adrenal insufficiency, whether this is primary or secondary, are usually overlooked, especially that the common symptoms of adrenal insufficiency, such as fatigue, weakness, anorexia, and nausea and vomiting, may actually easily be attributed to the presence of hyponatremia itself. To further complicate, not all cases of primary adrenal insufficiency are expected to present with hypovolemia. So some patients with primary adrenal insufficiency may not have hypovolemia. And this can be explained by three protective mechanisms. The first mechanism is that the presence of hyponatremia may create an osmotic gradient between extracellular and intracellular fluids, with fluids moving into the cells, causing cellular edema. When this occurs with circulating RBCs, this is going to increase the packed cell volume, and the increase in the packed cell volume may actually compensate for the presence of hypovolemia. This cellular edema occurring in the interstitial spaces may increase the interstitial pressure, and so this is going to increase the movement of fluid from the interstitium to the vascular space, which is going to compensate for the hypovolemia. And finally, the presence of initial hypovolemia may actually activate the sympathetic nervous system, which is going to produce venous constriction, improvement venous return, and increase in the cardiac output, which also may compensate for the presence of hypovolemia. Also, in 30 to 50% of patients with Addison disease, they may not have hyperkalemia. Also, 2 or 3 protective mechanisms have been postulated. This may be attributed to low dietary potassium. This may be explained by an intercellular shift of potassium, and this may be related to increased gastrointestinal losses due to the anorexia and vomiting known to associate a patient with Addison disease. Another explanation has been proposed that in patients who have autoimmunity, which is common in patients with autoimmune adrenalitis, or cancer, which is also another cause for primary adrenal insufficiency with bilateral metastasis, they have been postulated that there has been circulating cationic substances present in autoimmunity and cancer, which may stimulate cancer-sensing receptors in the ascending limb of lobe of Henle, which is going to produce a furosemide-like action, leading to natriuresis and kaliuresis. Adrenal insufficiency as a cause of hyponatremia is actually more important. However, because we have postulated that maybe we may have coexistent adrenal insufficiency and hypothyroidism, patients who have both disorders are more likely to be diagnosed with hypothyroidism than to be diagnosed with adrenal insufficiency, because hypothyroidism is more frequent, and that's why thyroid function tests are more often to be requested. And so a patient who have both adrenal insufficiency and hypothyroidism is more likely to receive a diagnosis of hypothyroidism, and this is going to mask the diagnosis of adrenal insufficiency. We know that this may create a threat to the patient, because if the patient is having both adrenal insufficiency and hypothyroidism, and he receives the diagnosis of hypothyroidism without receiving the diagnosis of adrenal insufficiency on initiation of levothyroxine, this may precipitate an adrenal crisis. The diagnosis of central hypothyroidism or secondary hypothyroidism, also it is a rather rare diagnosis. However, it is challenging. Classic teaching teaches us, we actually teach our students that in a patient with central hypothyroidism, you should expect that T4 and TSH both to be low. However, this is not the case in most of the patients with central hypothyroidism. As you can see here, these are 2 studies. They included patients who have central hypothyroidism, and they seek to report the distribution of TSH in patients with central hypothyroidism. So you can see here that in one study, only 12% of the patients have a low TSH. And in the other study, only 8% of the patients have a low TSH. So the classic picture that we teach for our undergraduate students is that in a patient with central hypothyroidism, you should expect low TSH occurs only in 8 to 12% of the patients. Actually, most of the patients with central hypothyroidism are expected to have a normal TSH. So in the first study, 71% of the patients had normal TSH. And in the second study, 84% of the patients have a normal TSH. Of course, we label such patients that they have an inappropriately normal TSH because this is not the appropriate response in the face of low free T4. Not only that, we should expect that some of the patients with central hypothyroidism to have a slightly raised TSH. So in the first study, 17% had raised TSH. And in the second study, 8% have raised TSH. So central hypothyroidism may exist in the presence of the majority of the cases with a normal TSH, and in the minority of the cases, they would have inappropriately raised or slightly raised TSH. And so this raises the problem. So if I have a patient who presents with low free T4 with a raised TSH, is this primary or secondary hypothyroidism? So actually, we have only one study to answer this question. So this study, having 55 patients with central hypothyroidism, and the aim study actually was to create a cutoff limit to differentiate between patients who have central hypothyroidism with a slightly raised TSH and patients who have primary hypothyroidism. So they have found that in a patient who has low free T4, in a patient who have hypothyroxanemia, a TSH of less than 10 microinternational unit per mil is a diagnostic for a patient with central hypothyroidism or secondary hypothyroidism with a sensitivity of 96%. In a patient who have hypothyroxanemia with a TSH greater than 25, this is discriminatory for primary hypothyroidism with a sensitivity of 97%. And there is a gray zone. If a patient who have hypothyroxanemia with a TSH that ranges from 10 to 25, then this may be explained on the basis of primary or secondary hypothyroidism. Another difficult differential diagnosis for patients who have central hypothyroidism is the non-thyroidal illness syndrome. So in a patient who is ill or critically ill, and they have this presentation, low T3, low T4, low TSH, this may be explained that this patient has central hypothyroidism, but it may also be explained that this patient is having severe non-thyroidal illness. And so how to differentiate between a patient having central hypothyroidism and a patient having severe non-thyroidal illness? So we go for this ratio. So we divide the free T3 by the free T4. If it is less than 2, this goes in favor of non-thyroidal illness syndrome. So what is the explanation? In a patient with central hypothyroidism, the primary event is a deficiency of the free T4. And the free T3 would be maintained due to a stimulation of deiodinase 2 that would maintain the T3 by converting the free T4 into T3. So the primary event is a deficiency of the free T4. The T3 would be maintained to some extent, and later it is expected to start to go low. So that is why when we divide the free T3 over the free T4 in a patient who has secondary hypothyroidism, we expect the ratio to be greater than 2. However, in a patient with non-thyroidal illness syndrome, the primary change, the very earliest change in the non-thyroidal illness syndrome is to have a low free T3. The decrease in the free T4 is the last change to be expected in a patient with non-thyroidal illness. So that is why we expect if we divide the free T3 by the free T4 to have less than 2. This study actually aimed to report first how common is hypopit as an explanation for hyponatremia, and how delayed is hypopit as an explanation to hyponatremia. So up to 40% of patients aged 65 or older presenting with hyponatremia may have hypopituitarism. Usually, the correct diagnosis is significantly delayed, and up to 5 admissions to several hospitals were required to reach the diagnosis of hypopituitarism. So it is wise to consider the diagnosis of hypopituitarism in patients who present with a SIAD-like hyponatremia. About the diagnostic workup, so actually we should consider testing for adrenal insufficiency and hypothyroidism in patients presenting with hyponatremia, simply because these two causes are common causes, as I told you, up to 40% in patients who are aged more than 65 years of age. But most importantly, the hyponatremia is readily correctable upon the correct treatment of adrenal insufficiency and hypothyroidism. So the diagnostic workup should include TSH along with pre-T4 in order to exclude secondary hypothyroidism, cortisol along with ACTH to classify the patient either having primary or secondary hypoadrenalism. So if the patient presenting with hyponatremia is in a stressful condition, so you go for a random cortisol. If it is less than 25, because actually we treat this stress as a stimulation test. So in a patient who is under stress, we expect the cortisol to be greater than 25. So having cortisol less than 25 micrograms per deciliter under stressful conditions, this may be considered as a sign of adrenal insufficiency. So this patient should go for a formal ACTH stimulation testing. And if the response is less than 25, you should diagnose a patient with adrenal insufficiency. If the patient is not stressed, and this is the difficult part, so you go for cortisol AM. If the cortisol AM is greater than 19, this excludes adrenal insufficiency. If it is less than 3 micrograms per deciliter, this is highly suggestive that the patient is having adrenal insufficiency. If the patient is having cortisol between 3 and 19 micrograms per deciliter, there is a possibility that the patient is having adrenal insufficiency. Both such categories should have a formal ACTH stimulation test. If after stimulation it is less than 20, you should diagnose a patient with adrenal insufficiency. The problem is that to add difficulty to properly diagnosing adrenal insufficiency in Egypt is that we don't have the regular ACTH. We only have the depot ACTH. So can we use synactan depot as a stimulatory agent to diagnose a patient with adrenal insufficiency? Actually, in countries like ours, in Turkey and in India, they have actually standardized a stimulation test using the synactan depot. So this study was conducted in Turkey. They have used 25 micrograms of depot ACTH, and they give the depot ampoule intramuscularly, and then they measure the cortisol at 0 before giving the ACTH, 30, 60 minutes. And actually our practice in Alexandria is that we add also 2 hours after the injection. And if the patient is diagnosed with adrenal insufficiency, if the response is less than 18 micrograms per deciliter, suspected to have adrenal insufficiency, the response is 18 to 21. And if the response is 22 or greater, this totally excludes the diagnosis of adrenal insufficiency. After diagnosing adrenal insufficiency, it is a must to measure the ACTH. So if the ACTH is high, and by high, we are referring to 2 times the upper limit of normal, this diagnoses primary adrenal insufficiency. If the ACTH is not high, that's to say, if it is low or inappropriately normal, this diagnoses the patient as having secondary adrenal insufficiency. So finally, we come for the real cases. So I'm going to show you three actual real cases of mine that I have encountered before with an initial presentation of hyponatremia, and they were revealed to have hypopituitarism. So this patient is 69 years old patient who presented with hyponatremia at the time of presentation, 123 milliequivalent per liter. The cortisol, when measured in this patient, it was 0.53. I told you that a morning cortisol less than 3 micrograms per deciliter is diagnostic of adrenal insufficiency. The ACTH was only 5.1, which is low, which is consistent with secondary adrenal insufficiency. The free T4 for this patient was 0.8, which is lower than normal, with a normal TSH. I told you that 70 to 80% of the patients with secondary adrenal with secondary hypothyroidism would have a normal TSH. So trying to explain the secondary adrenal insufficiency and secondary hypothyroidism in this patient, we ordered an MRI that revealed to have an empty cell syndrome. So this patient was treated with prednisolone 5 milligrams per day and levothyroxine 100 micrograms per day. We actually evaluate the adequacy of levothyroxine replacement in patients with secondary hypothyroidism by the measurement of free T4 with a target of having the free T4 in the upper half of normal. So this free T4 of 1.3 is considered to be adequate. In patients who have secondary hypothyroidism with a normal TSH at the time of diagnosis, they have to have a suppressed TSH to confirm the adequacy of replacement. So a TSH of 0.01 is actually confirmatory that this patient is having adequate replacement therapy. And just by replacing the adrenal insufficiency and the secondary hypothyroidism, this patient achieved a sodium that ranged from 134 to 143. The second patient was a young male, 27 years of age. At the time of presentation, he weighed 63 kilograms. He was actually a Libyan patient. He presented with acute hyponatremia. At the time of presentation, it was 115 milliequivalent per liter. He had one admission in Libya, and after being stabilized, he traveled to Alexandria. He had a second attack in Alexandria. And when they started to explore the causes of hyponatremia, actually, they started by ordering the cortisol AM, and it was less than 0.2 micrograms per deciliter. The ACTH was 1.5, which is low, indicating that the patient is having secondary adrenal insufficiency. Actually, when they screened the patient for the thyroid axis, they actually ordered the TSH. So by the time I saw the patient, he had only TSH done, and it was 1.4. For them, it was indicative that the patient is euthyroid. I ordered the patient to have free T4, and it was only 0.4, which is very low. So the patient in addition to having secondary adrenal insufficiency, he also had secondary hypothyroidism. So we ordered an MRI to diagnose the cause for secondary hypothyroidism and secondary adrenal insufficiency, and it revealed a diffuse enlargement of the pituitary gland, along with central thickening of the pituitary stalk with no filling defect, excluding that the patient is having a pituitary tumor. So this picture is consistent with hypophysitis. So one of the causes that I have mentioned for secondary renal insufficiency. So after receiving prednisolone 5 milligrams per day as replacement and levothyroxine 100 micrograms per day, the patient achieved adequate free T4, indicating adequate replacement with a suppressed TSH, and the sodium improved up to 130. The last case was an elderly female, 75 years of age. At the time of presentation, she had severe hyponatremia, 111 milliequivalent. The morning cortisol was 2.1 micrograms per deciliter, which is less than 3. The ACTH was low, indicating secondary adrenal insufficiency. So this patient had free T4 of 0.5, which is subnormal, with a TSH that is slightly elevated. So this is an example of the 17% of the patients who have secondary hypothyroidism with a slightly elevated TSH. So having a slightly elevated TSH does not exclude that the patient may have secondary hypothyroidism. Exploring the cause for secondary hypothyroidism and secondary adrenal insufficiency, we found that the MRI revealed at 26 millimeters flyvus bone cyst with upward displacement that's causing pituitary compression, a quite unusual cause for hypopituitarism. The patient received prednisolone 5 milligrams as replacement with levothyroxine 15 micrograms per day. So in spite of achieving a free T4 of 1.6, the TSH was not properly suppressed. So we up-titrated the dose to 75 micrograms per day. And so the patient achieved a high normal free T4 along with suppressed TSH, which is considered to be adequate replacement therapy for this patient. And after achieving adequate replacement for the hypothyroidism and adrenal insufficiency, the sodium rose and it ranged usually from 130 to 137. Actually, this patient has been following up with me for more than 5 years now. Whenever she goes into an acute illness, she always up-titrates her replacement to stress doses, and luckily she didn't develop an adrenal crisis ever since. So to summarize, adrenal insufficiency and hypothyroidism are readily treatable causes of hyponatremia. Replacement therapy. Primary adrenal insufficiency can be fatal if not timely diagnosed and treated. Secondary adrenal insufficiency is common, and it is a common cause, especially in elderly, for hyponatremia, and so you should seek to exclude hypopituitarism in all patients presenting with hyponatremia with a SIAD-like presentation. Upon diagnosis of hypothyroidism in the setting of hyponatremia, adrenal insufficiency must be excluded before starting the levothyroxine. The diagnostic challenges for us endocrinologists include the atypical presentation, the stimulation testing, which requires special agents, the non-thyroidal illness, which can be a differential diagnosis for patients with secondary hypothyroidism, and the unusual biochemical profiles the patient may present with. Thank you for listening, and I hope this was a fruitful presentation.
Thank you, Professor Tamer, for this illustrative and very interesting lecture illustrating the endocrine causes of hyponatremia. I can catch from this lecture some points like, of course, Addison disease or primary adrenal insufficiency is uncommon, but we face usually and the most common is secondary adrenal insufficiency. And this point is of great importance for us as nephrologists, as you said that use of corticosteroid for a long time is one of the causes for secondary adrenal insufficiency. And we use corticosteroid for a prolonged period in our glomerular disease and transplanted patient and so on. My question to you is, should we screen our GN and transplanted cases for secondary adrenal insufficiency, and when and how frequent, if we should?
Actually, there's no risk of secondary adrenal insufficiency as long as the patient is being supervised by a good physician. Usually, we see cases of secondary adrenal insufficiency when the patient starts to self-medicate himself. So a very common scenario that a patient who has, for example, bronchial asthma, who has been treated during an exacerbation with oral steroids. So the patient learns that taking this medication is going to improve my acute exacerbation. So later on, whenever he has exacerbations, he starts to take the medication on his own. So he starts to repeat the medication without medical supervision. And then when he tries to stop it, he's going to have acute adrenal insufficiency. But for you, autoimmune renal problems, or a patient who is a transplant patient, he is always supervised by a nephrologist. So even if you decide to stop the glucocorticoids, it is going to be gradually tapered. As long as you are gradually tapering the patient, this patient is not likely to develop adrenal insufficiency.
Yes. So the key is gradual tapering, but use
Yes.
for a long sudden tapering is a problem. My second question is how to suspect and diagnose Addison's disease and hypothyroidism in a patient with hyponatremia. We face many patients with hyponatremia. When to order this investigation for Addison's or hypothyroidism?
Usually, Addison is a differential diagnosis when we are encountered with hyponatremia with hypovolemia. Although I have mentioned that some patients with Addison disease may not have hypovolemia at the time of presentation.
Sometimes most of time we see.
For a patient with hyponatremia and euvolemia, we should suspect that the patient is having adrenal insufficiency or hypothyroidism. The screening usually includes TSH along with free T4. Ordering free T4 is a must because we have to exclude the possibility of having secondary hypothyroidism.
Yes.
And for screening for adrenal insufficiency, if the patient is presenting under a stressful condition, we may just order a random cortisol, and if it is less than 25, we should suspect adrenal insufficiency. However, if the patient is not under stressful condition, then we should order cortisol and ACTH 8 to 9 a.m. And according to the algorithm that I have shown, if the morning cortisol is less than 3 micrograms per deciliter, we should suspect adrenal insufficiency strongly. If it is 3 to 18, it is a possibility and we should go for a stimulation test. But if it is greater than 18 micrograms per deciliter, this excludes the possibility of having adrenal insufficiency. But there is a trick that we face in our practice. So what happens is that the patient presents with hypotension. He goes for the emergency department. In 99% of the cases, he is going to receive a saline solution along with a dexamethasone injection, either 4 or 8 milligrams of dexamethasone. The emergency department physician is going to instruct the patient, you go tomorrow morning and you should test yourself for cortisol. So under such conditions, when this patient goes for cortisol testing, we expect that the cortisol is going to be suppressed because the patient has just received dexamethasone in the solution. So he comes to us with the perfect trap. So he comes with a cortisol, usually suppressed way below the 3 micrograms per deciliter. So the key to discover such a patient is to ask him about the recent use of glucocorticoids.
Yes.
If the patient reported that he had such a solution with such an injection in the past, maybe 1 or 2 weeks, we should give him a proper space, at least 2 weeks before retesting the patient. And then actually, most probably, the patient would have a normal hypothalamic pituitary adrenal axis.
Okay. You recommend 2 weeks at least before doing cortisol?
Especially if the patient received dexamethasone or betamethasone. However, if the glucocorticoid that, for example, he has used is prednisolone, just 3 days would be enough. If the glucocorticoid that has been given to the patient is hydrocortisone, then actually only 24 or 48 hours would be enough.
Okay. You mentioned in your lecture that elderly patients have a high possibility of having secondary adrenal insufficiency. So if we face any patient above 60 with hyponatremia, we should screen for adrenal insufficiency?
Yes, I strongly suggest that. The 3 cases that I have shown you, 2 of them were actually above 69 and 75 at the time of presentation. So most probably this age group is a high risk for having secondary adrenal insufficiency and hypopituitarism.
how common the association between primary and secondary primary hypoadrenalism and primary hypothyroidism? Is it common to see?
Primary hypothyroidism is definitely a common disease. We don't have, of course, our data, the Egyptian data, but 2 or 3 years ago, Jordan had a nationwide survey, and they have found that 8.5% of Jordanians have hypothyroidism. So hypothyroidism is common. However, because a primary adrenal insufficiency is a rare occurrence, as I told you, 2 per million population per year. So actually, this combination is actually rare.
Yes.
What is more common to occur is that you may have a patient with primary hypothyroidism with secondary adrenal insufficiency due to Sheehan, or secondary adrenal insufficiency due to hypophysitis.
Why?
Sheehan and hypophysitis may be slightly more common than adrenal insufficiency.
Okay.
So they come together as part of autoimmune body endocrine syndrome. Because most of the cases of hypophysitis are actually autoimmune hypophysitis.
Okay. My last question is, do you have any explanation about the TSH is sometimes high in central hypothyroidism?
So actually, for this measurable TSH in patients with central hypothyroidism, they have found that this type of TSH is actually bioinactive. So it has an increase in the sialyl content. This increase in the sialyl content makes it inactive, so it cannot bind to the TSH receptor, and so it cannot exert a thyrotropic action, but it is present. The actual explanation for this is that currently we classify secondary hypothyroidism. We actually refer to both hypothalamic and pituitary as secondary. But actually, the cause may be hypothalamic or pituitary. So in pituitary, we don't expect TSH to be present. However, in hypothalamic cases, because the pituitary is intact, so the TSH can still be produced. However, as I told you, it is bioinactive.
Yes.
But it remains to be immunoreactive, and that is why it can be detected by the immunoassays. So in all the cases who have a detectable TSH, actually the cause is most probably lies in the hypothalamus and not the pituitary.
Thank you, Professor Tamer, for this highly illustrative lecture, and thank you, Professor Iman, for these talks, questions, and highly interactive questions. We have some questions on the chat. Can I go through them, please?
Of course.
Okay. Two questions about steroid. What is the dose and duration of steroid dependence? You mentioned a necessary not to stop suddenly, and suggested regimen to stop or withdraw. These have two questions from this. I think this is a very big topic.
Actually, it is not an easy answer. It depends on the dose, depends on the type, and it depends on the duration. So to make it simple, the longer the duration, so we need tapering. The larger the dose, so we need tapering. The longer the duration, the longer acting the type, so we need tapering. So if the patient is using a short acting for a duration that is only 1 or 2 weeks with a small dose, we don't need any tapering. So if we are using a long-acting steroid with a large dose for a duration that extends beyond 2 weeks, so we must have tapering. Of course, the tapering regimen would be different also according to the type. However, most commonly used glucocorticoid would be prednisolone. So if we start with a large dose, maybe 60 or 80 milligrams per day. So anyway, you start tapering because you need to maintain the therapeutic effect. However, you should go slower once you have reached the 20 milligrams per day. You should even go slower once you have reached the 5 milligrams per day. You may even go for an alternate day during the tapering. So after reaching 5 milligrams per day, you should go for an alternate day and then to stop the treatment. Usually, if you used a large dose for a long duration, after performing a proper tapering, you should test the axis. If the cortisol is less than 3 micrograms per deciliter, you should reinitiate the prednisolone and then try after 1 month. If the cortisol is 3 to 18, as I have mentioned, before re-establishing the glucocorticoid, you should go for a stimulation testing. If the stimulation testing excludes adrenal insufficiency, you don't have to re-establish the glucocorticoid. If it revealed adrenal insufficiency, so you will have to re-establish the glucocorticoid at the small dose, the 5 milligrams, and then you should try once more after 1 month.
Okay, thank you. Another question about should we test all the patients for all the endocrinal tests with hyponatremia, all the patients with endocrinal test you mentioned, or there is specific restrictions for these tests? And if it is related to the level of sodium, if there is any relation to the level of sodium?
First, should we test if a patient is classified in the first place as being hypervolemic? This excludes endocrinal causes. If the patient is classified as being hypovolemic, this opens the possibility of having Addison disease.
Yes.
However, if the patient is euvolemic, which is most of the cases, there is a possibility that the patient is having either hypothyroidism or adrenal insufficiency. So if the patient is classified as euvolemic, yes, we should test for both. About the relation between the level of the sodium.
The relation between to test recommendation for the level of sodium.
Adrenal insufficiency can cause mild, moderate, and even severe hyponatremia. However, for hypothyroidism, usually we should suspect it only in patients who have moderate to severe. However, for cases who have mild hyponatremia, hypothyroidism is not an explanation for mild hyponatremia.
Okay.
Excuse me, Dr. Yasser, any degree of hypothyroidism or hypoadrenalism or severe cases are associated with hyponatremia?
Definitely, there's a proportional relationship. So the more severe the adrenal insufficiency, the more severe would be the degree of hyponatremia.
Yes.
Okay, Professor Iman, Professor Said Khamis wants to comment, please.
Thank you, Professor Yasser. Thank you, Professor Tamer and Professor Iman, for this elegant presentation. Just I have two questions, if you allow me. Number one is regarding the drug-induced hyponatremia. What I mean here is the various medications can be used in hypo or hyperfunction of different endocrinal disorders, with focusing on diabetes or management of diabetes, especially with the newly introduced medication like SGLT2 inhibitor or GLP-1 agonist and so on. And by the way, diabetes is a second question. Diabetes itself can cause hyponatremia by various mechanisms, and one of the common mechanisms is the pseudo-hyponatremia, or what's called hypertonic hyponatremia, when severe hyperglycemia is there. So can we go through the diabetes as a big part of the endocrinopathies to reveal that diabetes can cause hyponatremia by what mechanism? And thank you so much.
So actually, this is the whole lecture. So if Dr. Yasser would allow us for in a future setting, that maybe we would dedicate a lecture for the association between diabetes and hyponatremia. As you may notice, I just talked today about hyponatremia. I did not touch potassium disorders. So if also Dr. Yasser would allow us in the future meeting and to deal with potassium and endocrine disorders, to give it its right. This deserves a dedicated lecture.
Will be our pleasure, Professor Tamer, to have a series of sessions about these endocrine disorders for electrolyte disturbances.
And I would be honored if
will be our
arrange this.
Of course, we'll contact you on this. Was in my thoughts to have a series for sessions regarding these issues. تفضل. طيب دكتور سعيد السؤال الثاني اتفضل. Second question.
ما هو السؤال الأولاني كان عن موضوع الدرج induced hyponatremia for various hypo or hyperfunction of the endocrinal disorders, I mean.
هو I'm not يعني properly prepared for the question. فعشان كده أنا حاولت إن أنا يعني أخليها
separate
future prospect.
No problem. Okay, thank you, Professor. Thank you. Sorry for disturbance.
Another question, Professor Tamer, about serum osmolarity. Does it have any role in diagnosis of these endocrinal disorders, or doesn't work with this?
I think the measurement of osmolarity comes before the consideration of endocrine causes. So only true hyponatremia should be considered for a possible endocrine cause. So after considering the hyperosmolar and hypoosmolar causes, then only true hyponatremia should be considered for an endocrine cause. Of course, that is after exclusion of diabetes. Diabetes is another issue.
Okay, Professor Sayed Al-Khashab wants to add a comment, please. Unmute yourself. Unmute yourself, please. Okay, I have a question, Professor Tamer, and I think this is a classic question. We have many patients with thyroid level you mentioned less than 10, less than 10. And we deal with this patient. The first diagnosis, differential diagnosis, is primary hypothyroidism, and we deal by doing antithyroid antibodies and following the usual algorithm. You know, if there is symptoms, if there is no symptoms, and taking the level of antithyroid antibodies. You mentioned here that this patient, we should think about secondary or central hypothyroidism. How can we differentiate these patients? And I think this constitutes a large number of patients that we meet in our clinical practice.
Okay, so we have to differentiate in the beginning between subclinical hypothyroidism and the situation that we are talking about. So subclinical hypothyroidism is by far the most common presentation of hypothyroid patients. So actually, more than 90% of all the patients with primary hypothyroidism do have subclinical hypothyroidism. The classic presentation for a patient with primary subclinical hypothyroidism is to have an elevation of the TSH. Usually, in most of the patients, it is less than 10, but in some patients, at least 20 or 25% of the patients is going to be greater than 10, with a normal free T4. So the hallmark of diagnosing a patient with subclinical hypothyroidism, which constitutes actually more than 90% of the patients that we expect to find in our clinics, are going to have this combination. Increase in the TSH in the face of normal free T4. So this is subclinical hypothyroidism, and this is most of our work. The issue here is that when you are encountered with a patient who comes with a low free T4. So in a patient with a low free T4, you have to look carefully at the figure of the TSH. So in a patient who has a low free T4, we should expect, if the patient is having primary hypothyroidism, to have a TSH of at least 25. So if you notice that we have low free T4, a low free T4, along with the TSH that is slightly elevated means higher than 4, but less than 10. So such patients, we should consider that this may be central hypothyroidism, especially if there is no concern about the accuracy of free T4. So if we encounter such a patient, first we start to ask him about risk factors of having central hypothyroidism. So maybe you would find the answer you would find the explanation with your first question. So did you have a previous surgery? Did you have a previous head trauma? Maybe you would ask about natal history. So in such a patient, maybe this is a patient with Sheehan syndrome, and she would tell you that she had problems in her latest delivery, and she failed to lactate her baby, and she had amenorrhea ever since. So you start asking simple questions about risk factors of having secondary hypothyroidism, whether this is head trauma, surgery, irradiation, or history of Sheehan syndrome or something. If the patient is lacking all evidence that he may have pituitary disease, consider repeating the test in a reputable lab. So maybe it is a fallacy of the free T4 measurement. However, if the repetition confirms to have a low free T4 with a slightly elevated TSH less than 10, then this patient should have an MRI of his cella, because maybe it would reveal an empty cella syndrome. One of the causes of central hypothyroidism that would be completely silent on the patient side is an empty cella syndrome. And I will tell you about a patient. So this patient came to follow up her hypothyroidism. So she had history of having hypothyroidism for the past 2 or 3 years. She was given a low dose of levothyroxine, and she always had a normal TSH. So for me, I considered that this is a patient, most probably she had subclinical hypothyroidism at the time of presentation, and that is why she is controlled on such low dose. So this patient was 45 or 46 years of age, and she told me that she's having amenorrhea. For me, I interpreted this as having menopause. However, during her follow-up, maybe 1 year after starting the follow-up with me, she complained of headache. She went to a neurologist, and the neurologist asked for a CT brain or an MRI brain. When she had the MRI brain, actually it revealed an empty cella syndrome. So with this new knowledge, I actually started to revise the diagnosis. So with the patient reporting that she has amenorrhea, I initially interpreted it as having menopause. So I asked the patient to perform FSH. If the patient is having amenorrhea due to menopause, I should expect that the FSH to be greater than 30. But actually, it was a low FSH. So this actually have changed my diagnosis. So instead of considering that the patient is having subclinical hypothyroidism, actually, I started to consider that the patient is having secondary hypothyroidism. And instead of interpreting the amenorrhea as menopause, I interpreted the amenorrhea as secondary hypogonadism. And actually, I started to recheck reevaluate the dose. I raised the dose. And as I told you in the presentation, in order to confirm adequate replacement of secondary hypothyroidism, you actually have to suppress the TSH. So I started to seek suppressing the TSH for this patient. So this can be tricky, and this trick actually me as an endocrinologist, I may fall to the trick. So this is not an easy question. And so I think the trick is to look for the free T4 against the value of the TSH.
The most important message is to look for the free T4 that could be the guide to differentiate between subclinical hypothyroidism and
central hypothyroidism with a slightly elevated TSH. Yes.
Okay. Thank you so much. Professor Iman, do you have a final comment and close this session?
Okay, no, I have no comment. It was very interesting session and illustrative, and it opens the door to many discussions. and inshallah for a new series about endocrinal causes of electrolyte disturbance. Many thanks, Professor Tamer, to be our guest today, and thanks for all the audience, and also great thanks to Professor Yasser Abdelhamid, who takes the responsibility of this great work for CME in nephrology and what is related to nephrology also. Many thanks to you.
Thank you, Professor Iman, and thank you, special thanks to Professor Tamer Elsherbiny for this very illustrative and very interesting comprehensive lecture about sodium disorders in endocrine, the endocrinal causes of sodium disorders. And as we said, we will have another lectures within this series about potassium and diabetes, hyponatremia, and etc. And we will discuss later on and follow on the coming year, inshallah. Thank you, Professor Tamer, for this very illustrative lecture.
Thank you, Dr. Yasser, for the invitation. Thank you, Dr. Iman, for hosting me.
Thank you, Tamer.
I was very honored. I was very honored to be with you.
Thank you. Thank you. Thank you so much. And excuse me to close. Thank you for all of attending professors and for all of the attendees. And again, for Dr. Hazem Abu Shusha for his work regarding this session and CME chapter. And excuse me to close. Tasbahu ala khair. Assalamu alaikum wa rahmatullahi wa barakatuh.